Started? I know. Started, sir. Okay. Dear friends, due to some computer problems and it is delayed. So today's topic is hemolytic anemia. So by definition, it is the self-destruction of one's own RBCs. By definition, that is the hemolytic anemia. So the RBCs will have an antigen over the RBCs membrane, which acts as an antigen. To this antigen, the body, knowingly or unknowingly, it will produce the antibodies against this antigen, results in a hemolysis. When that is one, and then usually the hemolysis occurs when RBCs survival is decreased less than 120 days. Normal RBC lifespan is about 120 days. The hemolysis usually occurs when the lifespan of RBC comes down. And if bone marrow does not compensate sufficiently, hemolytic anemia results. So regularly the RBCs, as they grow old and old, reach 120 days. Usually they are trapped in the spleen and they will be destroyed, and as a result some amount of bilirubin will be circulated in the blood as a normal phenomenon in the hemopoietic system. So if bone marrow does not compensate the loss of RBCs and it cannot produce enough number of RBCs, also may result in a hemolysis. The hemolytic anemia will have a Coombs positive and Coombs negative, which indicates the Coombs negativeness indicates a non-immune cause for hemolysis. Coombs positive indicates the immune mediated destruction of the RBCs. Sometimes it can be congenital hemoglobinopathies, enzymopathies, membranopathies. These are all the causes which can decrease the lifespan of RBCs and may get trapped in the spleen, and they may get destroyed early before they reach 120 days. And the defects in the presence of antibody bounded cell surface, autoimmune hemolytic anemia of red cell, hemolytic disease of newborn, transfusion reaction due to incompatible blood transfusion can result in autoimmune hemolytic anemia. And direct Coombs test, antigen over the RBCs will produce antibodies against antigens bound to red cell antigen. results in hemolysis. Excuse me. The membrane abnormalities of the RBC. One is hereditary spherocytosis. Excuse me. Elliptocytosis, acanthocytosis, stomatocytosis. Various shapes of the RBCs which are normal can have low lifespan, can be trapped in the spleen and get destroyed. They are all due to membrane covering the RBCs. Then some of them congenital, where they have defects in the hemoglobin. For example, thalassemias, where you have hemoglobin red cell enzyme defect like G6PD, pyruvate kinase, hexokinase, and glutathione reductase deficiency also can produce hemolysis and anemia. Thalassemias, of course, it depends. Beta thalassemia, beta chain is less. Alpha thalassemia, alpha chains production is less in the blood. The acquired immune related isoimmune, autoimmune, warm antibody type of autoimmune anemia can be present in a systemic lupus erythematosus, idiopathic lymphoma also, or chronic lymphocytic leukemia, sometimes ovarian teratoma, and drugs like methyl-dopa. These are all the things which are acquired. People who are taking methyl-dopa since a lot of years can develop acquired immune-related or isoimmune, autoimmune, warm antibody type like any type of autodestruction of RBCs can result in SLE and all these diseases like chronic lymphocytic leukemia, idiopathic lymphoma where cause is not known, and ovarian teratoma and the drugs and methyl-dopa. The cold antibody type, cold hemoglobin disease, that is the paroxysmal cold hemoglobinuria can result in certain conditions where people have a defect in the hemoglobin, where they develop cold hemoglobinuria whenever they are incidentally or accidentally or exposed to severe cold temperature. And then you can have mycoplasma pneumonia and lymphoma. These are all the conditions where you can expect a cold antibody type of paroxysmal cold hemoglobinuria due to damage of all the RBCs. Then some of them are drug related. The drugs which are adsorbed on RBC surface, example like cephalosporin, penicillin, methyl-dopa, The immune complex mediated sulfonamides and quinidine is also one of the drugs which can also produce autoimmune or immune mediated destruction of RBCs. These drugs will go and adsorb to the surface membrane of the RBCs, thereby the membrane gets easily destroyed. As a result, anemia results, bilirubinemia results. So then you have non-immune mechanical mechanical valves, which like your rheumatic heart disease patient having undergone with valve replacement surgeries like mitral valve, aortic, pulmonary, tricuspid, etc. can also damage the RBCs because they come in touch with the prosthetic valve. And then you have hemoglobin. As a result, patient can have hemoglobinuria. And hemoglobinuria also may be a result of infections like malaria can destroy the RBCs because during the erythrophoitic phase, the parasites will be infesting the RBCs and it gets swollen and the membrane stretches and ruptures and gives rise to hemoglobinuria and bilirubinemia. Like serious infections like Clostridium welshi infection, Bartonellosis also can result in a non-immune type of hemoglobinuria and hemolytic anemia. The drugs like nitrofurantoin, viper snake venom can also produce non-immune mediated anemias. So then you have dyserythropoiesis, also one of the reasons where you will have paroxysmal nocturnal hemoglobinuria. And the investigations like you can see the blood film shows polychromasia. That means many RBCs will have different colors in the sense not Eastman colors, but the pink color of the RBCs will be decreasing in intensity from low color of the RBCs and hypochromia and increased vacuolation and the size. Some of the cells will be having more size, that is macrocytosis. Some of the cells will have changes in they look elliptious, that is called elliptocytosis, and some target cells also will be seen, and especially in hemolytic anemias due to thalassemia, where you may get target cells. In the smear, you can see and identify. Then a direct Coombs test identifies RBCs coated with so you must do the Coombs test. It identifies the RBCs coated with antibody. The positive reaction indicates take the RBCs from the patient and you add the antibody to it. The positive reaction indicates immune reaction for hemolysis. That means there will be hemolysis. And you take the RBCs of a person who is suffering from autoimmune hemolytic anemia with antigens over the surface of the RBC membranes. Add a complement which is already prepared, already available in the market, in the lab's investigation. You add it, there will be hemolysis. That is Coombs positive. If you add the RBCs of a person who is not suffering from the RBCs of a person who is normal, add that complement, the RBCs may not be lysed. It is a Coombs negative. That means it's normal almost. Of course, Coombs negative hemolytic anemia can be present due to other drugs or mechanical processes or people who are put on hemodialysis where the pump usually pumps with a greater speed. It pumps the blood in the machine. That can damage the RBCs and can produce non-immune mediated hemolytic anemia. Usually, as we know, the lifespan of RBCs usually it is 120 days normally. It's a slight variation, of course, and which can be determined in the lab by labeling the RBC with chromium and a major site of RBC breakdown usually identified by chromium. You tag the RBCs with chromium and inject it. And watch for them, how long they survive in the body. Then urinary hemosiderin presence. So if you do test for hemosiderin in urine, if it is present, it indicates chronic intravascular hemolysis. That means it can be present in mechanical damage of the RBCs, people who are having prosthetic valves, or people who are undergoing hemodialysis. You can get urinary hemosiderin in the urine. Then other tests also you can do. Increased serum bilirubin usually will never exceed more than 4 to 6 milligrams in autoimmune hemolytic anemia. And LDH is also increased. And decreased hepatoglobin is a strong indicator of hemolytic anemia. You test for hepatoglobin, which is a strong indicator of hemolytic anemia. But increased urinary urobilinogen suggests hemolytic jaundice. Again, you test for increased urinary urobilinogen, that definitely suggests hemolytic jaundice. Then how do you manage the patient with autoimmune hemolytic anemia? Of course, in other anemias or hemolytic anemias we will discuss in the next classes. The management is treat the cause for both warm and cold autoimmune hemolytic anemias. Warm autoimmune hemolytic anemia, usually glucocorticoids are effective in warm autoimmune hemolytic anemia, like prednisolone 1 milligram per kg The response is usually seen in 10 days. Dose is tapered in 2 to 3 months of time, and given a minimum dose of prednisolone 5 to 10 milligrams a day at the end of 3 months. The intravenous immunoglobulin is less effective in patients with autoimmune hemolytic anemia. Splenectomy is usually effective for autoimmune hemolytic anemia. Then another drug, the monoclonal antibody, the rituximab 375 milligrams IV should be given once a week for 4 weeks. Is effective in the patients with autoimmune hemolytic anemia, rituximab. So then you see some of the pictures of the blood picture of autoimmune hemolytic anemia. అరే రాలేదా సారీ అందులో వచ్చింది రాలేదు చూద్దాం నెక్స్ట్